Can you all hear me? Is my audio okay?
Yes.
Yes.
Yeah.
All right, there are only three things inside your brain. I mean, inside your skull. Let's explain CPP. CPP is cerebral perfusion pressure. This is referring also to cerebral blood flow. There are three things inside your skull. We have brain tissue, which is about 80% of the volume. Then we have blood volume in there, which is about 10%. Then we have cerebrospinal fluid, which is 10%. So that accounts for 100%. So is there room there for additional, maybe a hammer you can put in there, a tumor, additional blood, or maybe increase CSF? Can you add any more if it's already 100%?
No.
No.
Impossible. So therefore, there's a concept known as Monroe Le Doctrine. This doctrine says that if volume in any of these three compartments increases, since we have already capped it at 100%, if there's any increase in the volume, say the examples I gave earlier was you have brain swelling, or there's bleeding in the brain, or there's a tumor growing in the brain, will it still be 80% if you have a tumor growing?
No, it will increase.
Right, it will increase. So let's say you have bleeding, such as in hemorrhagic stroke, for instance, and there's bleeding. Or let's say you have ischemic stroke, wherein some brain tissues died, but then anything dead always have swelling around it, right? So if you kill or injure a part of your body, there will be swelling because there's increased blood flow there. There's increase in there's inflammation, so there will be increase in volume there. Can you fit it there? Can we adjust this to maybe 110 and 120%? Can we do that?
Not really.
No, we can't. By the way, this doctrine here only applies to a intact brain. Okay, this only applies to, we are assuming that the skull, not the brain, intact skull. So as long as your skull is intact, the Monroe Le Doctrine applies. The doctrine again says that if volume in any of these compartments increase, then some of these components here have to be displaced. So the Monroe Le Doctrine is saying, if you have a cup of water, which is now filled to the top, if you add one more drop to it, this is a drop of water, what will happen to the total volume? Where will that drop go? If this is already filled, this is water. If it's already filled and then you add just one more drop, what will happen to? Okay, so this is what the doctrine is saying, meaning if you increase the volume in any of these compartments, because it's already 100%, so if you put one more drop in there, which will make this 101%, then something has to be displaced, right? So just like this cup of water, if you put one drop, then somebody has to go, right? So let's say just like if the elevator is full, okay, the elevator can only fit 12 people. And what will happen if you want to insert just one more person in there? Can we do that?
Someone goes off.
Yes, somebody else has to go out. Somebody has to give their spot to that person, right? Do you understand the doctrine?
Yeah.
Okay, and then again, keep in mind that this will only apply to an intact skull. If the patient is an infant or the patient has an open head injury, then the Monroe-Kelly doctrine does not apply. So I'm saying if a patient has a closed head injury, for instance, which is what we're trying to discuss tonight, a closed head injury, wherein the skull is closed, there is no open fracture. The patient is a grown-ass person, so the suture lines are closed. There are no open fontanelles, unlike that of an infant, for instance. So this Monroe-Kelly doctrine will apply. Are you with me so far?
Yes.
Okay. So so later when we get to this part, we will talk about brain herniation. Because just like this drop of water that will displace another drop, or the person in the elevator that had to leave and give their spot to another person, it will be the same in head injury, in a closed head injury specifically. So therefore, among the components here, which is inside your skull, we have brain tissue, we have blood circulating in there, and then we also have cerebrospinal fluid in there. So if we're going to displace something, so let's say the brain tissue increases by 20%, where will you take that other 20%? Because you said you agreed with me that somebody else has to go. So if it's an increase of 20%, do you have 20% that you can get rid of?
No.
Not really. So let's say you decide to displace CSF. Is it possible to displace all of that CSF out of there?
No, really, no.
No, the CSF in the ventricles are limited. Plus, you can't really displace all of them. Maybe you can displace half of it. However, even if we, let's say, if it's possible that we displace all the CSF, that's still only 10%. We need to displace something else. We need another 10% that has to go. Who do you think will volunteer? Can we displace blood volume?
Blood volume, I think, will be displaced. Yeah. It will
So
be.
we go without blood, screw the brain. So let's displace that blood out of there.
Yeah. I think that would be the next volunteer.
There will be no more blood flow to the brain then.
Mm-hmm. Yeah. I mean,
So,
brain, like if there's something there, yeah.
so you're going to displace the CSF and the blood volume to account for the entire 20%. So no blood flow to brain tissue.
Could it be the fat
What happened?
and the tissue?
This is what I'm trying to say. Is it possible to do this? Is it at all possible?
No.
No. So this is what I'm trying to explain to you how serious a head injury is, because there's really not much compliance here. Unlike, let's say, if you have, if this happens elsewhere, let's say in the abdominal cavity, especially in Mr. Scarda's abdominal cavity. So I have plenty of room. You want 100% increase? No problem. I got plenty of room here. Right? But not so inside the skull. The skull is probably the most, the worst place to have any injury, okay, any increase in volume, because really you really can't, you don't have much compliance here. So think of compartment syndrome when you talk about head injury. Okay, so let's review compartment syndrome. You learned, was it last semester, under musculoskeletal injuries, right? Yes. No.
Yes.
Yes.
That's it.
All right, so in compartment syndrome, what made those 6 P's appear?
Compression.
All right, so compression of what?
Pressure.
Compression of nerves, arteries, everything.
All right, so because of the increased pressure we're in, it's just like what happens in the skull. So the compartment in this case is the skull, whereas the compartment in musculoskeletal injury was the limb, right? What was the arm or the leg? And because of the injury, there was increased swelling, and then the skin acted like a tourniquet, right? So the skin, and in this case, it's the skull that's acting like a tourniquet, preventing expansion. So as a result, there will be compression of arteries, veins, capillaries, and even lymphatic and um, nervous, the nerves, right? So all structures are compressed. That's why you have the pallor, you have the paresthesias, you have the pressure, paralysis, pulselessness, and pain, right? Specifically unrelieved pain. So it'll be the same here. So it's like having compartment syndrome inside the rigid skull. Are you following the concept so far?
Yes.
All right. So let's go to your textbook now. All right, so this is traumatic brain injury. We have two. Of course, we have open and closed head injury. The problem here is there will be primary and there will also be secondary injury. The others here, just read this on your own. There's direct and indirect injury. We have shearing injury. There's actual injury to the brain, for instance. There's bruising or contusion or laceration. Now, the contusion and the laceration here, this will, of course, increase the volume of the brain and the blood, because with contusion, that's an actual injury to the brain tissue, correct? So of course, any injury will cause swelling that will increase the um, volume of the brain. It will increase the size because there is now swelling and inflammation. And same thing, if there's a laceration there, then you have blood. The blood here is not in the blood vessels, it's now around the brain tissue. So you've created another compartment here for that hematoma or that bleeding to which is now occupied by that lesion. So the brain bleed there, which can be from either traumatic brain injury or it could be from hemorrhagic stroke, for instance. So either way, you have a space occupying lesion there that you added to the volume inside the rigid cranial wall. Okay, so here, this will now, of course, increase intracranial pressure. The first thing we can displace, of course, is the CSF. But again, there's not much CSF in there. It's only 10% of the total volume. So really, there's not much compliance that's possible inside the cranium. So these are the examples. These are all just nice to know. Okay, so these are the possible causes of injury. So this could be a boxer, for instance, or a trauma victim. Somebody mugged this person, right? So they can either get an uppercut here or a blow from the back. The injury, the injury can be penetrating, or it could also be blunt force trauma. We don't know. So let's talk about the resulting injuries. So there will be primary and there will be several secondary injuries. We'll start with the primary injury first. Thank you for reading, Miss Sheena Easton. Is Sheena here? Yeah, there's 35 people in here. She should be in here. Or maybe she went to potty. Thank you, Maria.
Right. Primary brain damage occurs at a time of injury and results from the physical stress force in the tissue caused by blunt or penetrating force. A primary brain injury may be categorized as focal or diffuse.
Okay, thank you. So this is the injury resulting directly from the cause of the injury. So this is referring to the contusion, the laceration, the bleeding, the bruising. And whatever happened to the brain, this is the primary, this is the result, the direct result of the injury. The cause of the injury again can be either penetrating injury or blunt force. Okay, so either blunt or penetrating force. And the injury here can be focal, meaning only one area, or it could be diffuse, meaning involving the entire surface or entire brain tissue. And as I already described earlier, the brain injury can be open or closed, meaning your skull is open, obviously, an open head injury, or it can be closed. And just a reminder that if your injury is open though, whatever we discussed earlier about the Monroe Le Doctrine does not apply, because now we have plenty of room. We don't have compartment syndrome occurring, okay, in an open head injury. The Monroe Le Doctrine I was explaining earlier was only applicable to a closed head injury. We will go to Glasgow Coma scale shortly. We will go back to chapter 41 to discuss this as well as to practice scoring the patient. Now let's go to I believe there are 6 secondary injuries. Thank you for reading, Mr. Richards. Start here first, and then we'll go to the examples.
Secondary injury to brain injury includes any processes that occur after the initial injury and worsen or negatively influence patient outcomes.
Okay, pause for a minute. So secondary injuries are those that follow the primary injury, meaning the patient's problems haven't even begun yet. When we have primary injury, yes, this is a problem. Okay, there was direct injury to the brain, but it doesn't stop there though. There will be about 6 secondary injuries that will follow the primary injury. And what are these resulting from? Continue, Mr. Richards.
Secondary injuries result from physiologic, vascular, and biochemical events that are an extension of the primary injury. Keep going.
I didn't hear the last part. That extension of the primary injury.
And of the primary injury.
Okay. And what are some of those, sir?
Hypotension and hypoxia, intracranial hypertension, and cerebral edema.
Okay, there will be others, of course, okay, that will result. Let me go back to the whiteboard. What is this? Oh, this is something else. But this is not what I want. Okay, here. Okay. Okay. So cerebral blood flow, the formula, by the way, is okay, so cerebral perfusion pressure, which must be between 70 to 100 millimeters of mercury, by the way, is calculated by the mean arterial pressure minus the ICP. So we will look at later how we measure ICP. This will have to be measured invasively. So we'll put in a catheter or a screw or any other. There are several options to monitor pressure in there, but either way, whichever method we're using, it will be invasive because it's impossible to monitor it externally. So let's say your blood pressure drops because you have after head injury. Can you be bleeding? Can there be hemorrhage?
Yes.
Yes. Okay. And so let's say your blood pressure dropped to, let's say 100 over 60, okay, which is not bad. And then your intracranial pressure is between 10 to 15, I think. So let's say it increased to 18 millimeters of mercury. What is MAP? Can you calculate 100 over 60? So that's 120, 220 divided by 370, 310, 373 point and change. Okay, so minus 18 equals, this will be 55, right? Yes.
What did you say the formula was again?
Well, didn't you do MAP already previously?
We did.
Okay, so if not, then it's MAP equals 2 times your diastolic pressure plus your systolic blood pressure divided by 3. So 60 times 2 is 120 plus 100 is 220, 321, 10, 3, 9, so 73.33 something. So is this correct? 73 minus 18 equals 55, right?
Yes.
And our normal is 70 to 100. So if your your CPP, cerebral perfusion pressure, this is again the amount of blood flow in perfusing the brain. Okay, it has to be at least 70 to 100. So if it goes down below 60, below 60, CPP is already
Professor,
Professor, do you think are you writing?
yeah.
Yeah.
Oh, we can't see any of that.
Yeah.
Oh, I'm sorry. Why didn't you say anything?
Well, I mean, we thought you were just talking, but we kind of hear you clicking away. So I was like, what is he writing?
All right, so here is your CPP, all right? So this is what we're trying to constantly calculate. If you're caring for a patient with head injury, this is what you monitor. So cerebral perfusion pressure, the formula is mean arterial pressure minus your ICP, which is intracranial pressure. Normal CPP must be at least 70 to 100. 60 is okay, 65, because remember it was also the same with perfusion. In a patient with shock, for instance, or bleeding, we wanted our patient's mean arterial pressure to be 65, right? But in head injury, of course, we won't be happy with 65 because if it drops below 60, the neurons start to die, meaning brain cells will not survive. Okay, they'll start dying if the pressure drops below 60. So of course, we don't want it too close to that. We want it to be at least 70. So in this instance, because it's harder to control intracranial pressure because you understand Monroe Le Doctrine, right? I mean, because of that nature of the skull being a rigid compartment, it's really difficult to drop the pressure once it's already high. You can prevent further increases, but it's really difficult to decrease that pressure once it starts rising. However, can you control blood pressure though?
Way easier.
Yes.
Yes, we can increase blood pressure. One way is to agitate the hell out of the patient. You know, you hurl insults on the patient, call them names, you do fat jokes, or tell jokes about their mom that will increase their blood pressure, right?
Absolutely.
Yeah.
If they're a good son.
Yeah. The problem though is the patient's unconscious, so they won't hear all those insults. So we'll have to devise other ways in order to increase the blood pressure besides insults. So what would be your suggestions to increase? Because by increasing MAP, you can clearly see you can improve your CPP. Again, because it's difficult to drop the ICP. I'll show you later when we get to the interventions how hard it is, and we haven't even discussed the secondary injuries yet. So is it easier to manage the blood pressure or the intracranial pressure?
Blood pressure, absolutely.
Okay, so we can give fluids, right? We can give drugs that will increase blood pressure. We have midodrine. Okay, but your number one, of course, is to give fluids, right? So making sure you increase blood pressure, and then we'll also look at the other causes that will increase intracranial pressure, which again, although we cannot drop it, however, we can prevent further increases of ICP. All right, so our assessments and interventions will be all around managing cerebral perfusion pressure. So this is our concept in how to care for a patient with head injury. Any questions so far with the formulas?
All good.
All right, so let's go back to secondary injuries. All right. So hypotension and hypoxia can result after the primary injury. Now, how does this happen? Well, depending on, this is all trauma. Okay, remember, this falls under traumatic brain injury. So in a trauma, let's say you either got mugged, or you're in a car accident, or you're riding a bike and got hit, or you were drunk and fell off the train tracks, or you have epilepsy, you have a seizure, and then you fell off the train tracks. What else? Somebody stole your cell phone, and while chasing after them, you fell into the train tracks, right? Or let's stop with the train tracks. So any manner of trauma here that causes head injury, all right? So will it involve some kind of bleeding?
Yes.
Yes, okay, it always involves some sort of bleeding. And then we'll look at later the effects of the brain herniation and how it will actually make things worse. So when you're bleeding, what happens to your blood pressure?
Drops.
Drops.
And what happens to oxygen delivery now?
Drops.
Hypotension and hypoxia both will be possible, right? After any trauma. Now, you just saw the effect of hypotension on cerebral perfusion pressure. Was it good or bad?
Bad.
Very bad. And oxygen. All right, so what have we learned in fundamentals or in MedSurg 2 when we talked about oxygen and its effect on blood vessels? So what do you think the response will be for the body when your oxygen levels drop or your carbon dioxide levels rise? Because that's what will be happening, right? So if your oxygen's low, that means your CO2 will be higher. So if you have hypoxia, that means you now have a higher level of CO2. What will happen to the blood vessels?
Vasoconstriction.
Hypoxia. Will they constrict or will they dilate?
Dilate.
Because now there's less blood flow to the brain. So what do you think the brain blood vessels will do? Will they dilate or will they constrict. And
Constrict.
I mean, they will dilate. I
Dilate.
don't know. The dilation would be, to compensate for the blood volume for perfusion. But
right, that's
but
correct.
if we have hypotension, what wouldn't the blood vessel constrict?
Okay, normally, yes, I forgot to mention this part. The part of the weirdness of cerebral circulation is besides, you know about the blood-brain barrier, right?
Yes.
Yeah.
Okay, so that's one thing exclusively found in only in cerebral circulation. You don't see that anywhere else. There is no such blood-brain barrier anywhere else in the body. That only occurs in the brain. There's another thing that only happens in the brain. In response to the injury, whenever the cerebral perfusion drops, or this one, for instance, the PaO2 is less than 80 instead of 80 to 100, the patient actually, the brain automatically responds instead of vasoconstriction because of the sympathetic nervous system response. This thing doesn't affect the brain. The brain, because the brain wants to preserve blood flow, it does not want to restrict blood flow. So therefore, instead of constricting, something really weird happens in cerebral circulation. The vessels dilate in order to increase um, oxygen delivery. So this is what it means by if the PaO2 drops less than 80, it does restrict blood flow to the brain. So therefore, the response, instead of vasoconstriction, which is normal in all other body systems, right? Because we're trying to raise blood pressure, this doesn't happen in cerebral circulation. What you have instead is vasodilation. Are we clear with that so far?
Yes,
Yes.
sir.
And then this one only happens in the brain. Okay, because the normal response is vasoconstriction, but not so in head injury or in cerebral circulation. Another weird thing is, in response to the injury, it's really related to the cerebral perfusion pressure. The blood pressure automatically rises whenever there is brain injury. It doesn't matter whether it's traumatic brain injury or if it's a stroke. So later next week, or maybe later today, tonight, if we ever get to stroke, one of the responses you'll see um, after a stroke is the blood pressure rises automatically. It really has something to do with decrease or increase perfusion pressure. Hypertension. What is the effect of it on CPP?
Professor, you were cutting off. We
Does it
didn't hear.
raise or lower
Completely
CPP?
cut off, Professor.
We didn't hear anything. You got cut off.
Okay. I was saying one weird thing about head injury besides vasodilation is the brain automatically raises blood pressure. Because as you can see here, what is the effect of hypertension on CPP? Is it good or bad?
Good.
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 Good or bad?
Good.
Good.
It's actually good. The higher the blood pressure, the higher the CPP, as you can see here. All right? So this is actually a self-preservation response by the brain. It's very selfish, but it does the job. Okay, it does the job of saving at least the brain itself. So the higher the blood pressure, the higher the cerebral perfusion pressure. So this is something you should consider. So we talked about this briefly earlier. So our goal, is it to raise or lower the blood pressure?
Raise it.
We actually want to raise it. However, we also don't want it to be really high. I'm not talking 180. Okay, I'm talking around 140, 150. Okay, that is the ideal blood pressure there. Because let's use this example for instance. So if we change this blood pressure now to, let's say, even 140/90, which is hypertension technically, right? So what is the MAP with 140/90? So that's 180 plus 140, 320 divided by 3, 106. So look at your CPP, your MAP now. MAP changes to 106 minus 18, you have 8, 9, 88. Is this good or bad?
That's good.
Bad.
That.
Good or bad?
You said
Oh,
normal
that's
was
good. That's good.
70.
Yeah, between 70 and 100. Yeah.
Yeah, that's good.
Okay, good. So that's why this is how the body, specifically the brain responds. So whenever it is injured, or whether it's from trauma or from a stroke, it automatically raises the blood pressure because it's beneficial for the brain. It knows that when the intracranial pressure rises, which is also always what happens when you have injury, whether again caused by trauma or caused by stroke, it raises the ICP, and therefore it needs to raise the blood pressure in order to maintain cerebral perfusion pressure. Are we clear on this part so far?
Yes, sir.
All right, so let's go back here. So is hypotension and hypoxia good?
No.
No. So therefore, without looking at the interventions, when a patient has head injury, what do we need to do to the blood pressure?
Raise it.
Increase it.
What do we need to do to the oxygen level?
Increase it.
Increases.
What are the first two things you should administer when a patient has head injury?
Oxygen and fluids.
Very good. And oxygen, you need it to be at least 80 to 100. Unfortunately, though, most head injury patients come in unconscious. So your breathing there isn't very good. So you may need to intubate this patient as soon as they come in. And plus there are causes also, we'll discuss those shortly. Next is ICP. So our normal ICP is 10 to 15. Like I said earlier, we have only 3 things that should be inside the skull. We should only have brain tissue there, blood volume, and CSF. We cannot add any more. So there are things that usually we do on a daily basis that increase ICP. Examples are the following. So when we cough, sneeze, or bear down, for instance, we get these every day. Plus, we party every now and then. So let's say, when was the last time you had a hangover, Mr. Basam?
How long ago?
Long ago. Who has a more recent experience?
Right now.
Okay, who's that? Was that Luis?
Yeah.
Okay, all right. So, what did you have besides alcohol that gives you a hangover?
Is sugar in the alcohol?
No, I'm just saying, what besides alcohol, what did you have, with the alcohol? Usually you at a party.
More alcohol?
Drugs.
Shots.
Well, I did eat something.
Yeah, that's what I'm trying to ask. So what did you have with it?
I had seafood pasta.
All right, what else? Is there any cheeses involved or some chocolate maybe?
No.
Any other, I'm trying to, add more tyramine besides alcohol. because alcohol has tyramine, right, which is a vasodilator. So it will get worse if, let's say, along with it you had some, or let's say maybe not, not beer or hard drinks. Maybe it's wine. Okay, wine have cheeses with it, right?
Red.
Yeah, so all of them have high tyramine content. So they are all vasodilators. So we just discussed vasodilation earlier. So what will happen to blood volume when you dilate blood vessels in the brain? What will happen to the blood volume?
Will increase.
It's going to increase blood volume. And therefore, will it lead to increased ICP?
Yes.
Yeah, so that's why a hangover will give you a splitting
Headache.
headache. So therefore, a headache is the one of the symptoms of mild increased ICP. Same thing also when you're coughing like crazy or you're giving birth to a really big turd. So or sneezing like crazy. You get a headache, right? Because these cause increased ICP. They all lead to increased blood volume to some extent. Okay, so sustained increases as long as they don't result in pressures greater than 20 though, as long as they're under 20 of increase in ICP, that you're fine. Okay, as long as also they're periodic, meaning not sustained. Okay, you understand this part, right? That it's only a sustained if the sustained increase is greater than 20. That is already serious. All right. And this is the Monroe Kelly doctrine here. So this is what we discussed earlier. So if volume in one component or compartment is increased, then it has to be compensated by a decrease in the volume of the other compartment, I mean component. So again, we only have three things inside the skull. We have the brain, we have blood, and we have CSF. So if one of them increases, whether it's the blood, something else has to be displaced. Okay? A volume in the other component must decrease. And the example they gave here is the CSF is shunted or displaced. However, is there enough CSF that can compensate for the increase though? That can be displaced in response to the increase? Is there ever enough CSF? Not if it's only 10% of the total component, right? So you don't have a lot of give here. Before we go to the brain herniation syndromes, okay. So increased ICP is the leading cause of death from head trauma patients who do reach the hospital alive. Every time I talk about this chapter, I'm reminded of one of our graduates in 2015 or 2016. I think it's 2016.
Yeah, 2016.
Okay, so you were aware of Arthur, right?
I thought you were talking about Dylan.
No, it was Arthur.
No, don't remember that one.
Yeah, and Dylan too. So what happened to Arthur was it started as a fender bender. The problem was it was on the interstate. So when he went out of the car to inspect the damage, and these idiots on the highway they never gave anyway, so he got hit and then went flying over the barrier and sustained a serious head injury. He was alive for maybe 48 hours maximum in the ICU, and of course if you have severe head injury, your prognosis is not very good. So I just saw him 2 weeks before that accident. He came to the office because he was on his way to take the NCLEX. You know, he was getting some pointers, you know, and then we had a good talk. And then, yeah, 2 weeks later, this happened. Um, anyway, his girlfriend, who was also a graduate, so she was there the whole time, the whole 2 days with him, and then finally, you know, after he passed, and so she was, you know, the funeral was over. Then he came back and we talked about it. You know, she was able to discuss it at that time, and she just said everything she learned in chapter 45 was exactly what she saw in the ICU. So with Arthur, so they talked. She talked about the signs and symptoms, what the interventions were, what the no CPP calculations were, medication, and unfortunately the prognosis as well. That it was really really poor. You know, he never made it. So let's discuss this part here with why the brain herniates. 942. So let's go to 41. I think this picture is better. Okay, let's use this one. Okay, so let's say this is your skull. And this is Kadim Richards. Okay. May have drawn the skull a little too big, but so we said brain is 80%, right? And blood and CSF are both 10%, 10%. All right. So if the head injury caused an increase of at least only maybe 20% or more. Okay, so there is severe swelling here, or swelling here because you had a coup contra coup injury. So it bounced here first and then it ricocheted and then hit the other opposite end of the skull. Okay, so it got jarred pretty good because of the trauma. So you hit this part first, number one, and then you hit this number two as it ricocheted. So you have two areas here severely injured. So you have bleeding here and swelling, bleeding and swelling here. And then because that increased to 100% now, brain is now 100%. So you have to find ways to account for displacement. So let's say we're able to maximum displacement here is 5, another 5% displacement here, that's only 10. So we're still missing another 10. And based on anatomy, where is the only opening in the skull? In an adult skull?
The ovale, where the spinal cord goes.
Okay, so we call this the foramen magnum, right? So this is where the spinal cord exits. Okay, so if we're going to displace 5%, 5%, and this is already, that's the max. We need to displace 10% more. Which structure is closest to that opening?
Brainstem, medulla.
This one right here. So some of it will have to be squeezed out into that hole. So you try squeezing something so big into something so small, what is bound to happen? So this is just like when you have a hernia. So you have a small opening in your abdominal wall and you try to squeeze a piece of bowel out through that small opening. What will happen to the bowel?
Strangulation.
Okay, so you try squeezing something this big into something this small. What will you also have?
Yes, strangulation.
Brain herniation.
Increase the pressure also.
Same thing, same strangulation. So there will be ischemia because you're pushing it out here because of the increased ICP. So after displacing the maximum blood you can, the maximum CSF you can, plus again, there's additional bleeding there. So this could be more. Okay, it would be beyond 20% increase because not only is there brain swelling, there's also bleeding. So you may have a hematoma here, another big hematoma here. So that will increase the volume even more. So now the more you squeeze that brain out, and then it just so happened, what is the function of the brainstem when you squeeze that thing out of there? What is the brainstem responsible for?
Reflexes.
Vital.
Reflexes.
Something more vital.
Respiration.
Breathing.
Okay, respiratory rate is there. What else?
Circulation.
Sorry?
No man.
Blood pressure, right? Regulation. Heart rate. So your vital signs are controlled by your brainstem. And not to mention your reticular activating system is also in there. So this is responsible for your consciousness. So therefore, without again getting to the signs and symptoms in the textbook yet, what will be the patient's changes when you have increased ICP, or especially if you have brain herniation now? What would happen to your consciousness?
You lose consciousness.
All right. So this is where our Glasgow Coma scoring will now come in. We will see the patient's severity of the injury using the Glasgow Coma scale score. And again, so your respiratory rate will drop, blood pressure will drop, heart rate will also drop. So that explains your brain herniation. Let's go back to 942. We'll just finish the secondary injuries and then we'll go on a break. Regardless of the type of edema here, you can read each type, vasogenic, cytotoxic, or interstitial. It doesn't really matter because all this is explaining is the three mechanisms by which edema forms inside the cranium. However, regardless of how it forms, edema is edema. Does it increase ICP?
Yes.
Yes, because edema will be a space-occupying lesion inside the brain. It will increase volume of the brain tissue. So therefore, it will increase ICP. Next is hemorrhage. So we kind of discussed this already earlier. Now the hemorrhage here can be two. You can have hemorrhage inside the brain, in which case it becomes a space-occupying lesion, increasing ICP, or the hemorrhage here can be somewhere outside the brain, wherein you're losing blood, which will lead now to the first two secondary injuries we talked about earlier, resulting in hypoxia and hypotension, which doesn't really, either way, it doesn't help the case. But in the case of hemorrhage occurring inside the cranium, which now becomes a space-occupying lesion, it doesn't again matter whether it's subdural, epidural, subarachnoid bleeding, it's still inside the skull and therefore will become a space-occupying lesion. The severity though varies. Let's say for instance, if you have a subdural especially, because these bleeds are very seldom going to form fast because most of the time they will be a venous bleed, unlike subarachnoid bleedings or intracerebral bleeding wherein they're usually arterial. In the case of a venous bleed, the symptoms are not acute. It develops over several days, and the patient may not seek help, or let's say common scenario is this happens in a nursing home. So a patient is seen on the floor, and of course these patients are smart because they've already had this happen before, wherein they had a fall. And what do you do for those who work in a nursing home? You see a resident on the floor. What happens to that resident? What do we do next? What will that resident have to endure? What is our post-fall protocol?
Check neurological.
Right? So you do neuro checks, but before you even, after you do your initial neuro checks, which is done every 15, right? Times 2 hours and then drops to every 30 and so on. Where do you send the patient?
The hospital?
Right. So we call EMT, we call the doctor, and then doctor orders send the patient to the ER to have a CAT scan, right? And then how long before they come back to the facility? Can easily be.
It depends on if they're admitted or not.
Yeah, so most of them, though, because there's no symptoms, they will not be admitted. So at the time of the injury, though, if it's a venous bleed, although we can see it, but because of the patient's experience, you know, this is, I remember what happened the last time I fell. So I sat in that damn ER for 8 hours, and then, you know, total 12 hours, and then I came back to the nursing home, and then they did all these. So if you were the patient, what will you do the next time they see you, you see them on the floor?
Pretend like I didn't fall or try to get up.
Exactly. They're gonna try to get out of that miserable experience of laying in that ER with all these people, and then waiting for your turn for the CAT scan, and waiting for the doctor to read it. So they will just say, "Oh, I'm fine," you know, and then yeah, I didn't hit anything hard. In fact, I'm sitting on a pillow. Okay, so you can see here, see, there's a pillow under my butt. I didn't even hit anything, right? So, and the nurse says, "Oh, you just fell, and then the pillow just happened to be on the floor, and then you fell right on the
Or
pillow."
lie at them.
Yeah, exactly. That's exactly how it happened. Okay, very good. Plus, it's the end of the shift. So, what's the nurse gonna say? You want to stay over and do all that paperwork? Of course.
No.
Yeah, the nurse was okay. Okay, so it's just between us, all right? Thank you. So you're sure you're okay? All right, let's just keep us on the lowdown. And then 2 weeks later or 2 days later, this patient goes unconscious. Okay, because they had a subdural bleed. They had a subdural hematoma, and then that's it. So here's a critical rescue regarding subdural hematomas or epidural hematomas, because they're equally life-threatening. So you have to monitor this patient early. So let's say you decided not to send this patient there, kept it on the lowdown. This is what you'll have to be doing though. The changes though, it's up to you if you want to take the chance on your license. Because they can go downhill pretty quick once the symptoms appear. So really it's not only for the patient's safety, but your if you intend to keep your license, then you have to do what you have to do. Next is hydrocephalus. This is, although this will not be common in most head injuries. However, if you do have enough swelling, meaning this is in the case of diffuse axonal injuries rather than focal, there will, because of the swelling, then it will compress the brain structures, of course, and may impair reabsorption of CSF, because CSF is normally produced and drained constantly, just like the aqueous humor in your eyeball. So if after the head injury, because of the swelling, it may cause a decreased or impaired absorption of CSF, increasing the CSF, causing a hydrocephalus. Then, of course, the CSF component here increases, then it becomes another cause for increased ICP. And then finally, this is your most serious secondary injury. Now you have brain herniation. It can herniate three ways. You can have uncal herniation. You can also have central herniation, or you can have also lateral herniation, or you can have a combination of both. So it will go both downward and then sideways at the same time. Testable parts here are the manifestations. You have to recognize the symptoms. So this one I highlighted specifically. What are your signs of a central herniation? Chain stroke respirations, pinpoint non-reactive pupils, and the hemodynamic instability here is, of course, hypotension and bradycardia. Any questions on secondary injuries before we proceed?
You said hypotension and bradycardia, the last two words that you said, right?
Yes. Later, we'll talk about those three because they're part of the Cushing's triad, but we'll do that after the break. So we'll continue with this page at 7:30.
All right.